Hey, I am on. Video. Hello, everyone. Pulling up your chat as we speak. Welcome to the show, everybody. It is another episode of the Dr. Dustin Show. Is it all in your head? That is the question we are asking tonight. How many of you have been told all of the pain is just in your head, maybe by a family member, a well-meaning friend, perhaps not so well-meaning? How demeaning can it feel to be so invalidated, to have someone say that? We've definitely talked about that before. That is not what we are going to promote tonight, certainly even if the pain is in your head. And by the way, it is kind of, because that's where it's processed. But no, it's not something you're making up. Quite the opposite. It's very a well-studied phenomenon, what makes people think the pain is in your head. Of course, I am referring to the placebo effect. That is what we're going to talk about tonight. The placebo effect. Placebo meaning Latin, meaning to please, actually, to please. And so, pain management really is probably the best subject for the study of the placebo effect. Certainly that has been well demonstrated in the literature. And that just is a testament really to the subjectivity of chronic pain and how we really have a hard time measuring it, right? It's not like cancer where we can look at a lab value or look at an imaging result and say you have it or you don't. Pain is just subjective. You can be totally normal looking, especially if you have chronic pain, right? And you're sitting in the waiting room just watching the TV, not sweating bullets, not crying tears. But your pain is a 10 out of 10, right? You've lived with it for so long. Unfortunately, nobody else can appreciate that. And so they say it's just in your head. Well, I want to get into some of the science tonight so that we can understand kind of where we're coming from, give some interesting clinical insight into the placebo effect, and also some messages for our physicians who might be watching and the importance of certain behaviors and actions in how we relate to our patients. And then hopefully as a patient too, maybe you don't feel so gaslit. I've heard a lot of times patients will say, yeah, my doctor just upsold this treatment like you would not believe, and I felt like I was being sold a bag of goods. Well, maybe you were, maybe you weren't, but there is some logic behind why we do what we do. So we're going to get into that tonight. Going back to the chat, hello everybody. Thanks for making it tonight. Kate Bakes, I see you. Lugnut, welcome to the show as always. So we're going to get right into it tonight. So as I mentioned, most of the knowledge about the placebo effect does come from the field of pain. Tonight I'm referencing an article that was published in 2011 in Pain Physician. And there's a lot of really interesting tidbits in here, so stay with me. Placebos were widespread in medicine until the 20th century, and they were sometimes endorsed as necessary deceptions. So imagine that. I guess before we had the real stuff, they had to fake it until you make it. And that was the way of the land for so long, for such a great part of our medical history. Necessary deceptions. In 1961, the much-quoted Henry Beecher, a surgeon, found that patients of surgeons he categorized as enthusiasts relieved their patients' chest pain and heart problems more than skeptic surgeons. So already in the early mid to late 1900s, we were already seeing effects of the placebo effect, not just medication, but in how physicians related to their patients. And so this paper covers some interesting models of the placebo effect. Essentially, the first model we're going to talk about is this general model. So it's a reassuring message such as, this treatment is very effective and will bring you quick relief. Or this treatment is usually effective and provides relief for most patients. This approach to patients has been shown to provide positive results, right? So how many times has your physician said, yeah, most of my patients do really well with this treatment? Or at least half get pretty good results, and the side effects are minimal. I think it's worth a try. Now, that may be directly related to the literature, or it might be a little bit of fluff to say, hey, you know what? It's going to be okay. This is going to work for you, right? Just that alone has been shown to provide positive results. The physical characteristics of a placebo medication, right? So the pill we're talking about, the color, the size, the quantity, all these different variations have also been shown to have an effect on the placebo. So, for example, 2 pills are known to be more effective than 1 pill, right? Perhaps the bigger the pill or the more brightly colored. They've even shown differences between generic pills and name brand pills, both placebo, but the name brand will result in a more positive effect than the generic placebo, interestingly enough. And I've been subject to that as well. I mean, I don't know if it's placebo. It certainly could be. But for some reason, for me, taking the brand Tylenol medication works way better than taking a generic version of acetaminophen. Comment if that has been your experience as well. I know that something, just regular good old Tylenol works better for me. Invasive techniques such as intravenous administration of drugs and surgical treatments may produce more pronounced placebo effects than non-invasive treatments, such as topical treatments or oral medications. So almost like the more we do, the more you expect it to work. And I think this also might be a big reason why a lot of patients prefer surgery, right? They just want us or a surgeon to cut the pain out, right? Whatever the problem is, there's a disc herniation, it needs to be fixed, like throw the kitchen sink at it. So there's definitely a mental sort of aspiration there. Finally, conducting follow-up investigations, either as a booster session or assessment of side effects or effects of toxicity, may also contribute to the placebo effect by reinforcing the idea that the active ingredient has been administered. So we start a new medication, we follow you back up in 2 weeks, see how you're doing. It's like, okay, well, we're reinforcing the fact that you're taking this medication, that it should be working, that it is working, maybe 10, 20%, right? But hey, it's still early. We're going to give it some more time. Let's continue to build that optimism, and that alone can be therapeutic. These factors are relevant as the placebo will be more potent if it is congruent with the beliefs, values, and goals adopted by the patient, right? So if a patient comes in and they're very anti-medicine, but then the treatment is like, well, you need to take this medicine. Even if you convince that patient that it's the right medicine for the right condition, it may not be super effective because, again, that patient really didn't want medication in the first place. Same thing is true with injections, right? Patient comes in and like, hey, I will do anything it takes to not have an injection. I'll go through therapy, I'll do medications, but then sometimes there is doctor gatekeeping, right? And they say, well, you're not going to get this medicine unless you do this injection. But again, maybe that patient really did not want the injection. That therapeutic treatment is not aligned with that patient's goals. So really, what are you doing in that case to help the patient except to appease the DEA, as they say? Even though the DEA has nothing to do in this case with that particular scenario. So again, it's so important to get to know your patient because that is where the therapeutic effect lies. So there's this thing called conditioning theory. Pavlov came up with this in the, I guess the 60s, whenever Pavlov was around, a long, long time ago. So it has been demonstrated that in a placebo-controlled trial of antidepressants, once the trial was over, the patients who had been given placebos quickly deteriorated. So again, they were conditioned to expect a certain outcome based on the medication, and they got worse once they stopped getting the medication because they were conditioned to think that the medication was helping them. It has also been shown that if a placebo is described as a muscle relaxant, it will cause muscle relaxation. And if described as the opposite, it will cause muscle tension. A placebo presented as a stimulant will have an effect on heart rhythm and blood pressure. But when administered as a depressant, the opposite effect occurs. It has been shown that alcohol placebos can cause intoxication and sensory motor impairment. Okay, so again, what is the treatment? What is the treatment that we're offering? If all of it, perhaps not all of it, and that is an accurate statement, it is not all of it, but a significant part of it is what we believe or what we expect or what our prior experience has been or what our relationship is with our physician. All of these factors that are in our psyche at that moment, if that is what steers the outcome of treatment so strongly, what really is the medication doing? Interesting thought. Another theory is the expectance theory. So this was put forth by Goldstein in 1962. The expectancy effect can be enhanced through factors such as enthusiasm of the doctor, differences in size and color of the placebo pills, or the use of other interventions. In one study, the response to placebo increased from 44 to 62% when the doctor treated them with warmth, attention, and confidence. And that was a little bit sad to me because I hear so many stories of how obtrusive or direct or in and out or impersonal or even rude sometimes the physicians or nurse practitioners or physician assistants can be. Unfortunately, you may have the right medication, the right injection, the right treatment for the right patient, but if it's not delivered in a nice, warm, cozy package, it may not be as effective as you want it to be. The most important expectancies are probably related to the nature of the patient-physician relationship, the physician's attitudes and behaviors toward the patient, and the enthusiasm for the treatment being recommended. Wow. So again, unless you've really mastered the art of selling a treatment, so to speak, I can see how that might come across as gaslighting. And I'm not saying that, let's say, a certain type of malevolent gaslighting, doesn't exist. I'm sure that it does. Certainly, after hearing many of your stories, gaslighting generally is not a positive term, but there is something to be said for, let's say, talking up a certain treatment or talking up a treatment plan that can instill some confidence in the patient, and it is within that confidence that a positive outcome can be realized. So there can be certainly a positive outcome from that. Neurobiology of the doctor-patient relationship and the mechanism on how the appropriate words could activate the endogenous opioids or dopamine system has been described, which in essence improves the outcome of the treatment. Right. So it's important to have good relationships with your doctors, and of course that's going both ways, physicians and patients. So now this is like you mentioned, this is an article from 2011. It's looking at review articles from even many years before. What is the most recent research showing? Well, I would love to show you. There's a new medicine on the market called Jornavix, and many of you have maybe heard of this medication. It was FDA approved for the treatment of acute pain, I think maybe a little over a year ago now. And it was exciting when it first came out. It's a sodium channel blocker, and it really is the first type of new class of pain medication really in decades, probably since NSAIDs were popularized in the 60s and 70s. Okay. Yeah, we've had pregabalin and gabapentin, and we've had, SNRIs like duloxetine since then, but really those are just repurposed medications. This is a brand new class. So it's exciting news. And I'm sure some of you, I know some of you anyway, patients that I've encountered have found positive relief, and others maybe not so much. Of course, it is only FDA approved for acute pain. Post-surgical pain probably is the most common use for it. However, there is some off-label use going for chronic pain and research ongoing for chronic pain. So maybe we'll see something of an approval for that in the future. Well, let's look at what those study results showed for the approval of Jornavix. Okay, so here we see on the screen on the left-hand side, there's trial 1, and then trial 2 is on the right-hand side. Both of these are minor surgical procedures, the abdominoplasty on the left and the bunionectomy on the right. And so you can see on the left, both of these, by the way, had 48-hour treatment durations. So they're looking at pain from, I guess, time 0 to 48 hours later, which is, I think, appropriate perhaps in an acute pain setting, post-surgical setting. I mean, in most cases, you may not get even opioid therapy for 2-3 days, often after a procedure like this anyway. So they looked at the procedure there. They randomized patients to either receive Jornavix or a placebo or hydrocodone, which might be considered the standard of care. Let's go to the next slide. This was the first one with the abdominoplasty. So you can see here that the baseline scores amongst all 3 groups were relatively the same, 7.3, 7.5, 7.4. And then they all changed from baseline after taking these 3 medications. So on a scale of 10, they reduced by so they went down by 3.4 points in Jornavix, 2.3 points in placebo, and 3.2 points with hydrocodone. So the exciting outcome of this was that there was a 47% reduction in pain with Jornavix and a 43% reduction in hydrocodone. So Jornavix was at least as good as the hydrocodone, plus they did not have any side effects that could be related to hydrocodone or the risks of taking hydrocodone. Now that's what got the headlines, and duly noted. That is something worth putting up in lights and getting it approved. That's all fantastic. What is interesting is the placebo. The placebo effect had 31% reduction in their pain. They got sugar pills, and they had 31% reduction in their pain. And by the way, part of doing a double-blinded placebo-controlled trial is that you don't tell your patients that they're getting a treatment that's really going to help them. You give them a treatment that says, well, you have like a 33% chance that it's the Jornavix, 33% chance that it's placebo, or a 33% chance that it's hydrocodone. Okay, it is what it is. So you have sort of a neutral approach. They still had a 33%. Well, based on the studies and everything that I just showed you, imagine if they had a doctor that they liked, they had a good physician relationship, patient-physician relationship. They were generally an optimistic person. They went into this knowing that the medicine was going to help with their pain. I bet you that placebo effect would actually go up quite a bit from 33%. You see what I'm saying? But even if we go back to that slide, we look at a 31% and a 47%. That what is the math on that? 9 plus 7, 16? So there's a 16% difference with Jornavix. Again, we talk about, state-of-the-art medication, right? Very expensive medication, and we're still just 16% better than placebo. Of course, hydrocodone itself came in even under than that, 12% better than placebo. Hydrocodone, 12% better than placebo. That was for the abdominoplasty. study. Let's look at the bunionectomy study, which is this slide right here. Again, you can see the baseline pain scores pretty much the same across the board, 6.7, 6.8. And the reduction, again, in the pain score, -3, -2, -3. So the percent reduction, again, with Jornavix, 51%. A little bit less than hydrocodone this time around. Hydrocodone reduced pain about 53%. And then placebo itself reduced its pain 38%, again, with a neutral approach. Imagine if they had a positive swinging approach. But even still, 13% difference. So Jornavix was 13% better than placebo. Hydrocodone 15% better than placebo. So it's very interesting, this concept of the mindset and the expectations and the optimism, really, of a patient and the physician who's promoting the treatment. That cannot be undersold, I don't think. And so, yes, this is the reason why there's hesitancy, perhaps, on behalf of the physician community who understands these studies, understands the concept of placebo, understands that patients may have certain expectations. And, look, a lot of times patients are super jaded, and understandably so. They've been, chewed up and spit out by a system that doesn't care about them, right? So then they go into another physician's office with this sort of jaded appearance. And, unfortunately, that can make it challenging for a positive outcome to occur. It's almost like we're speaking negativity into existence. And by the way, same is true for doctors, right? If you're so jaded to the point that you can't bring that positivity to the patient encounter anymore, or have just a few minutes to make that connection and make sure that the patient feels good about what is happening, then really what are you doing? I mean, other than spinning your wheels, maybe collecting a paycheck, right? That is just no way to live. So that's the show. That's the idea of the placebo is it has to be respected, but also there may be more going on behind your encounter. If you feel like your patient or your physician is just upselling something, they may just be trying to help you. Anyway, that's my 2 cents. Let's get into the chat. What's going on here? Lugnuts left me a few comments. Let's see here. Yes, you can meditate and help guide your mind to deal with the pain better, at least for a little bit. Yes. So it may not be a treatment in and of itself to just have a positive mindset. We've talked about that certainly with our music video, 8 Patients. No, pain management is more than just a vibe. There's no doubt about that. However, you can't discount it as a tool in the tool belt, so to speak. It's almost like a handicap. If you have a negative mindset, right, you might as well at least give yourself like the best chance possible, and that's where the positivity comes in.
I have a quick question. What does the N stand for on those charts where it says N equals?
That's just the number of patients studied.
Oh, okay. Yep. Gotcha.
Yep. Lugnut says, I could have saved a lot of expletive. Sorry, I almost said it. A lot of money if I could have gotten a placebo. Yeah, like I said, they've been studying placebos or dealing out placebos really for probably the majority of healthcare on this world. But somewhere along the way, it did become unethical to give patients placebos. I have heard of one patient. This is a true story, but I'm not going to reveal any names. But this patient, his mother was addicted to opioids, and his mother was a little bit advanced in age, and he felt that she was a danger to herself, and he couldn't get any doctor to listen or agree, because he felt in that moment, well, what does it matter if she's addicted, as long as you can keep track of the pills, et cetera, et cetera. But from his perspective, again, I did not endorse this. Don't shoot the messenger. This is all that has happened. Okay, I was just told this story. But he worked with a pharmacist, actually, who took sympathy on his plight and his mother's plight. And so compounded a sugar pill for them, which she thought, of course, was an opioid medication. And this is technically illegal, should never have happened, but I don't know the names of the people involved, other than I met this person at one point. So it is what it is. But from what I heard from the son, she took the sugar pills as if they were her typical pain medicines, and she did not experience any negative side effects, and she went on to live out her years without trouble. So, there you go. But, it is considered to be, yes, generally unethical to provide or prescribe placebo medications. It is still an area of study, however, but we do have to check certain boxes. So the American Pain Society, they recommend the use of placebo in clinical trials when there is limited harm to patients from delaying the actual treatment, when the alternative active treatment is unproven, right? So whatever they're comparing it against, it's not already a proven treatment method. And when there is substantial potential benefit to future patients in establishing the efficacy of a treatment and or avoiding side effects of a treatment. So again, whenever you are designing a study like this where placebos are in play, you typically do have to have some oversight and make sure that you're checking off these boxes because first, we do no harm as physicians, and so we want to make sure that we're being as ethical as possible. But yes, Lugnut, I'm sure the placebos... Actually, you know what? This brings me up another story. I'm going to get into it. You want me to get into it?
I'd
okay.
love it, yeah.
I'm going to get into it. Probably the more you pay for a treatment, the better it's going to work. So, again, this idea that, well, the more expensive guitar is going to sound better than the cheap one. The more expensive purse is going to be better quality than the cheap one. You guys remember that show? They did like an expose on this. They like put up a shop in a mall and they made it all super high end with fancy names, and they like put the brand names on the actual, merchandise, purses and shoes and things of that nature. And then they upmarked it like $2,000-$3,000, like you would expect to see. People were coming in. They were like, "Oh, this is so nice." They were like talking, and because they were doing a documentary on the grand opening, and so they were like talking about how nice the quality was and how good of a deal it was at $3,000. And then at the end of the day, they exposed to everyone that actually all of this was actually just purchased from TJ Maxx for like $30-$50. And yeah, you just thought it was worth because we charged you, high price. So, they didn't take their money, but they made the point that it's this expectation that, well, because I'm paying so much money for something, it's probably going to work better. So there you go. Yep. Yes. So, the latest garbage drug, yeah. It's again, it may be helpful for acute pain. I don't know. The studies are pretty. It's 2 studies. It's not like we have a significant number of studies. It's not like we have a big meta-analysis of this medication, or it's even been around for more than a couple years. But I just think it's exciting because it's like a glimmer of something that could be better than what we have, and we're always looking for something better, right? There's nothing wrong with that. But yeah, in my clinical experience for the management of acute pain, it really seems like 50-50 for me so far, although I really haven't seen too many patients on it. It's kind of an expensive drug, to be fair, but I don't know if we're at a stage to totally trash it yet. Certainly, I wouldn't use it for chronic pain. We just don't have long-term studies to support its use, and it is what it is. Plus, it's super expensive. So, but yeah. Any other questions tonight, guys? It's been kind of an interesting topic. Is it all in your head? No. But does your head have a role to play? Absolutely. That is the conclusion for tonight. So if you found this video at all to be helpful, do leave a comment below. Hit that thumbs up button and the little bell, which will let you know when we have more shows coming. We have shows all week this week. Jose with Strength and Recovery is his new brand, so to speak, as it is the sister brand to Baseball Strong. He's got some good stuff coming up. And then, of course, we have Katie Lovett and all of her interesting insights on nutrition. And then Keith, again, is back on Thursday. So it's been great. Hit that like button. I will see you next time. Until then, be nice to your doctor. And doctors, be nice to your patients. See you then.